It was not able to handle the team. It doesn't occur with Zoom actually. But anyways, we have very limited topics to discuss, so let us continue with that. Let me open the first one. The first one we were discussing was learning and memory. So I'm opening the PowerPoint now. Let me share with you the PowerPoint which I am able to see. Go there. Where is the opening PowerPoint? Okay, here. Something went wrong. What went wrong, Baba? Okay. So hopefully now it should be able to do that. Hopefully you are able to see the PowerPoint now.
Yes, we can see it.
Yeah, we can see.
Okay, so let us go ahead quickly now because revision should not take a lot of time.
We stopped at stages.
Yes. So the thing is, in memory, what as a physiology student who is going towards clinical now, what you should know about these topics, I'm going to focus on. So this is what you have to remember. What is memory exactly? At the cellular level, it is nothing but changes in the neuronal synapse. Okay, so whenever you are trying to learn something, a person tries to learn something, basically some changes occur at the level of synapses. Whatever those changes occur, they are called as memory trace. Please remember this word, memory trace. Now we come to the stages. So what happens in these stages? First, the brain identifies for any information which is the circuit. So it selects different neurons, different circuit together and makes a temporary new circuit through which action potential is running. That first stage is called as encoding. Okay. Once this circuit is decided for any new information, it will be practiced to make it stronger. Make it stronger, yani easier for the circuit to be activated. Okay. So that is done by storage stage where the information is repeated again and again. Okay. How do you repeat the information again and again? By running action potential in that circuit again and again. Okay. So that is our second stage, storage. Okay. Third stage is to ability to recall that information, yani ability to reactivate that circuit. That is called as retrieval. Okay. Now, here is the thing. Whether you understand it or not, please remember always things will occur in this step encoding, storage, retrieval. E S R. Okay? Will sometimes this thing will occur? Retrieval first, then encoding, then storage. Will it occur?
No, it has to be in order.
It has to be in order. First, you have to identify the circuit, then make it strong, and then you are able to reactivate that circuit. Simple as that. Okay. So always remember this sequence encoding, storage, and retrieval. Okay. So that was our most important point, number 2. Let us go ahead. So different types of memory are there, short-term memory and long-term memory, and all those things are there. You should know. Then what is positive memory? That is important. Positive memory is nothing but a short-term memory where there is increased sensitivity. So smallest of trigger will cause positive memory. Okay. So that is called as sensitization. So if you know positive memory and a sensitization, that should be kifaya. Okay, here is another thing about memory which you should know, the types of memory. So as we discussed in our lecture, types of memory, there are, in general, we can say theoretical memory and practical memory. So we have memory which we can talk about or express or declare. So declarative or explicit memory and a theoretical memory, it may be factual knowledge or it may be personal experience. Okay. And then the second type is procedures. Okay. So that is called as implicit memory. Now the explicit or declarative memory is facts factual knowledge or personal experience, both. So these are the classification. Please remember the classification. Okay. Now we come to the clinical aspect. First thing, very important thing which you have to remember here is hippocampus. What is the function of hippocampus? Hippocampus makes new memory. Please remember that. The ability to decide which information to remember is done by hippocampus. It has the authority to decide and tell the brain, okay, brain, remember this information. Brain, forget this information. These orders are given by hippocampus. So hippocampus makes new memory. If hippocampus is damaged, the person will not make new memory and he will have anterograde amnesia. Damage to any other part where memory is stored, damage to any other part will cause inability to recall old memory. That is called as retrograde amnesia. Please remember the difference between anterograde amnesia and retrograde amnesia. Second thing which you will remember is the function of hippocampus. Okay. What is dementia? Loss of memory plus decrease in intelligence plus change in personality. This is dementia. You know the examples, many examples are there. So this is all in this lecture. Any difficulty here?
The examples are
No,
Alzheimer and senile atrophy, right?
Yeah, kifaya. Alzheimer kifaya. Okay?
Okay, thank you, doctor. Clear.
Good. Let's go ahead to the next topic now. The next topic was are you able to see the next topic?
no, not yet.
Wait a second. You're able to see now, right?
Yes.
Yes.
Good. So it is about sleep and EEG. Here we first talked about EEG. So I explained you what is electroencephalogram. It is a non-invasive procedure to record electrical activity of the brain through the surface of the body. Okay. So mostly on the skull. Okay. So that is electroencephalogram. I told you about different mechanism, how the waves are recorded and synchronization and desynchronization occurred. But thing which is very important for you to remember is the types of wave. Okay. So the waves are classified based on frequency mainly. Okay. So all waves with frequency less than 4 are called as delta waves. Theta is between 4 to 7. Okay. Alpha is 8 to 13. Beta is more than 14. These are the numbers you have to remember with the name. I cannot explain you again and again. It will not change. You have to memorize it. Can you remember this?
Yes.
Yes, doctor.
Okay, so you have a patient with some complaints, so many complaints, half page of history is given, and then on the EG recording is shown in the picture. You count the number of waves, you found that the person is having 6 waves per second. So which type of waves is this person is showing?
Theta.
Theta waves. Simple as that.
So
Once
doctor,
you know the frequency, you will be able to identify.
we might have
Okay.
pictures in the block,
You might have.
or just us.
You might have anything. You should know the basics. Once you know the basic, don't worry about what is there in the history given, what are the reports given. Once you know the basic, extract that information. I'm not going to ask you anything which you don't know. Isn't it?
Okay.
So the question can be in any form, but the point of learning is this one only. What are these waves called as? So this frequency is called as this is this. Memorize this and search for that information. Okay? You'll be able to automatically identify. Okay. Second thing, in the history, clue may be given. So one of the clue is mentioned here. Are you able to see this slide?
Yes.
Are you able to see what I have selected?
Yes.
Very good. So in the history, clue may be there. The person was having closed eyes, he was relaxing, and he was not having any mental calculation or anything. Random thinking was going on, wandering mind. and his frequency was 12. So which waves are seen? It will be alpha waves, isn't it? So
Yes.
history will have this clue also. Therefore, you should know alpha waves are seen during this condition. Okay? Please, very, very important things we are discussing here. Please remember. Okay? Now, one of the most important thing here is person is having mental activity, he is thinking, his eyes are open. At that time, which wave you will see? The frequencies are around 15, 16, 20 something. It will be beta waves. Any confusion here?
Clear, doctor.
All clear, doctor.
Now, the most important confusing point here is the person is sleeping. Okay? And some other signs and symptom of REM sleep will be shown. His heart rate is increased, his basal tone is extremely decreased, respiratory rate is increased, flushing is occurring on the skin, and his waves were this, maybe other things of REM sleep like dreams are remembered, may be given. You have to identify which wave will be seen if you test this person. Which wave you will see?
Beta waves.
Beta.
Beta waves. What will be the frequency of those waves?
14 to 30.
Yes, any wave more than 14 you will see. Am I right or wrong?
Yes.
Very good. Okay. Now regarding theta and delta, I told you these together are called as slow wave sleep. Please get used to these words. Slow wave sleep. Okay. Remember their frequency 4 to 7 Hz. They are seen in stage 2 and stage 3 non-REM sleep. Don't forget the word non-REM. Okay. So don't forget this word non-REM sleep. Stage 2 and stage 3 of non-REM sleep. Okay. Delta, as I said, in general, they are not seen in young adult. They will be seen in very old. So history will itself tell you the baby was very young, maybe 2 years or less, or the person is 80 years or more in general. Okay. Now, apart from this, there are certain other ways which are seen during sleep. Two very common ones we talked about. One is sleep spindle and other is K complex. Okay. These two, if the history is given, the person's EEG was recorded and we found there were sleep spindle and K complexes. So in which stage you see this?
Stage 2.
So what is the stage of the person?
Stage 2, right?
Stage 2 non-REM sleep. Okay. Don't forget the word non-REM sleep here. Okay. Okay, these are the functions of EEG where they use, but we are focusing on sleep, so we'll skip this part. We'll go ahead directly to sleep. So in EEG, we discussed about different stages of sleep. So here is the different stages, non-REM and REM sleep. You should know that. You should know that sleep is an active procedure, not a passive procedure. That is all. Okay? Don't go into the details. You should know that it is an active process, not a passive process. Okay. Apart from many other functions related to restoration, repair, and immune development, the one of the most important function you will remember is consolidation of learning. Memorization occurs during sleep stages. Okay. So remember that. Now let us see the stages of sleep. In general, the stages are non-REM sleep, then REM sleep, then again non-REM sleep, then again REM sleep. Like this cycle goes on again and again. Okay. So this is how the stages go. Non-REM sleep is further divided into 4 stages. Stage 1, stage 2, stage 3 and stage 4. What are the major things in each stage you have to remember? For example, in stage 1, what is the most important thing? Stage 1 sleep.
Drowsy
Where is
sleep?
stage 1?
Drowsy?
Where are the slides related to stage 1? Okay, I skipped. Here it is. Okay, so it is a drowsy sleep as you said, very right. But in symptoms and signs, sometimes this will be given. So please remember that. Occasional jerks and twitches occur when you are falling asleep. You can see this especially in children. When they are falling asleep, suddenly one of the hand will move. It will show twitches, maybe facial expression will change for a second or so. Okay. So that is stage 1 sleep. What is the speciality of stage 2 non-REM sleep? It will show sleep spectral and K complex.
Yes.
Okay. So stage 3 and stage 4 are deep sleeps, slow wave sleep. They are called as stage 3 and stage 4 non-REM sleep are called as slow wave sleep or deep sleep. Okay.
Yes.
What is the speciality here? The parasomnias, activities in sleep children do. They are usually occurring in this stage. Sleepwalking, sleep talking, bed waiting, and others. Okay, night terrors. So they occur in deep wave sleep. Any difficulty here?
Clear, doctor.
Good. Okay, now we come to the most important type of sleep, that is REM sleep. All the diseases we talk about, majority of them, sleep related disorders. Okay, not the quantity or quality related, but behavior related disorders occur in REM sleep. So therefore, clinically, this is very important. Okay, so in general, REM sleep is a small part of our sleep. 20 to 25% of our sleep is in REM stage. What is unique here is, here the person, even though the eyes are closed, they are moving rapidly in jerky way. Okay. So the eyes will be moving in this way, therefore called as rapid eye movement sleep. Okay. What is another unique thing is, the EEG recording will show beta waves which are normally seen in an awake person with eyes open and thinking, isn't it? So those same waves they are seen during REM stage of sleep also. Yani the person's brain is very active even though the person is very deep in sleep. One of the most important thing is the dreams are remembered in this stage. Okay. The tone is extremely decreased, suppressed. Rest, everything is increased. Heart rate is increased, metabolism is increased, respiration is increased, and many other things are increased. The only thing which is decreased is tone, extremely decreased. Please remember these signs and symptoms. History is made around these points. Okay, clinical cases are made around these points. So you should remember that.
Doctor, and non-REM sleep, everything is decreased, right?
Yes, every biological parameter is decreased. Even tone is also decreased, but the other things are also decreased. In REM, tone is decreased, just like non-REM sleep. Even more decrease occurs of tone in REM sleep, but the other are increased. Brain is very active, body is very active. Heart, lungs, and every other organ is active more than normal, isn't it?
Yes.
So this is REM sleep. Any difficulty till this part?
Clear.
Good. So in the abnormalities, we will not go into the details. You just need to know the names of the disorders. So we have dysomnias and parasomnias. Dysomnia and disorders related to quantity or quality of sleep. Disorders related to quantity or quality of sleep. So here we have insomnia, hypersomnia, sleep apnea, and narcolepsy. So obviously we will not go into the details. You may need to identify only insomnia. Okay. Parasomnias, you know, sleepwalking, sleep talking. I don't expect you to know the alternate terminology. The simple word sleepwalking, sleep talking is sufficient. Okay. This is all in the sleep lecture. Any question? Sleep etiology lecture.
Clear, doctor. Thank you.
Thank you so much, doctor.
Okay. So what I'll do now is open the next lecture. So next lecture we are having is spatial senses vision lecture. Okay. So let me share with you. Where is the Shehab?
Doctor, I actually have a question in the previous lecture, but you don't need to open the slides for it.
No issues. Please ask.
About the muscle tone, if they're decreased in both, how is there a jerking movement in the REM?
Just a second, please. ना
Okay.
भैया थोड़ा 5 मिनट के बाद लेक्चर चालू है 10 मिनट बाद में Okay, please, what is your question?
I was asking about the muscle tone. How is it decreased in both non-REM and REM when REM has a jerking movement phase?
Was REM having jerky movement? My first question, please.
Stage 1
Uh,
non-REM.
Stage 1 non-REM, occasional jerks do occur. Very good. But what about REM? Are there any jerky movement in REM?
Was it REM or non-REM? I think it was non-REM, yeah.
No, actually in both the stages I use this word. Let me explain you where I used. In non-REM, only in stage 1, occasional jerk in the muscle of the limbs. Okay? Otherwise, tone is decreasing in non-REM stage. But in stage 1, occasional jerk can occur. Okay?
Okay. But in REM also
regarding REM,
yeah.
here also tone is decreased. But the eye movement is occurring. Yani there is more tone in the muscles of the eye only. Are we clear?
Yeah, I understand now. Okay.
Rapid eye movement. REM yani rapid eye movement.
Yes. Okay.
Clear? So that is
Yes.
the confusion here. Now
Yes.
remember, normally, logically, we will think that the tone should not decrease in REM stage because everything is active. Heart is active, lung is active, metabolism is active, brain is active, isn't it?
Yes.
It is just an evolutionary safety mechanism.
I see. Yeah, okay. I understand.
Evolutionary safety mechanism because in REM stage, practically our brain is very active. We are thinking something. Okay? Most of the time we are consciously aware of those thoughts. Many times we may not be aware. Okay? And if we start acting those dreams or thoughts because we are sleeping, we may not be aware of that. We start acting, we may cause harm to ourselves or somebody else, isn't it?
Okay, yeah. Okay.
Therefore, the natural evolutionary
It's protected.
mechanism has suppressed the tone exceedingly. So whatever your thoughts are going on or dreams are going on, the person will not be able to move or act. Okay?
Yes,
So that
I
is the
understand.
purpose here.
Yes.
And this safety mechanism is disturbed sometime, and that has resulted in Western countries in murders also. Okay?
Oh.
So the doctors and scientists had to prove that the murder caused by this person was during sleep, and it can occur due to REM disorders. So there is a
And
classification nowadays for REM disorder for this type of activity.
Okay, that's interesting. But does the person remember? Because dreams are remembered in REM phase.
Yes, exactly. Now the problem is we cannot prove whether he remembers or not. He simply says that I was sleeping. I don't know how I came here. I don't know how I see blood everywhere or the person dead here. Okay.
Okay.
So that is the case here. So the onus now lies on doctors to prove that he is having REM disorder.
Oh,
Okay. And that is a difficult task to do.
Yeah, it is. Thank you, doctor.
So that is how it is done, that you have to, the defense counsel then prepares doctors and tests where the somnology tests are done, and they prove that during REM stage he is not working normally, the tone is not decreased, and whatever other findings are there. I also don't know much details about those. Okay?
Yeah, but it's interesting. Yes, thank you,
It's
doctor.
really interesting. Okay. So this is all about the sleep and EEG. Please remember those things which I have told you. Let us go ahead to the next lecture, that is vision. Are you able to see the PowerPoint?
Yes.
Yes.
Vision PowerPoint, right? Okay. So let us go ahead with that now. Now this was special senses. I told you about the things which we need to understand here. In general, about all special senses, remember what is special about it. Okay. So for eyes, we have mechanism which will collect light from different direction and focus it on receptors. So we have transmission and refraction, what is the most important part. Once the light reaches the receptor, it will be converted into action potential. That is called as transduction. Rest, you know, it is easy, isn't it? So the most important part of this lecture will be transmission and refraction, how light is transmitted. Okay. So for this, you come to this anatomical structure. We have discussed the anatomy, the three layers, and the different compartments. Please revise them on your own. Okay, these are the three layers, and what is the content of each layer is mentioned here. So you should remember that. So here is one first important thing, the role of iris. Okay. So we have iris muscle, which has got two different types of muscle. One is circular and one is radial. Okay. So the radial muscle is dilator and circular muscle is constrictor. So this will be pupillary constrictors and dilators. Okay. So please remember them, pupillary constrictors and dilators. Now we come to the next slide, which is the first physiology related slide, NA light reflex. Okay. Please remember what is direct light reflex and please remember what is consensual light reflex. Direct light reflex yani when the light is stimulating one eye, the same eye will constrict. The same eye pupil will constrict. That is called as direct light reflex. And what is consensual light reflex? When light is shining in one eye, the other eye will respond by pupillary constriction. That is called as consensual light reflex. Any difficulty till this part?
Clear, doctor.
Clear, doctor.
Very good. Very good. Okay. In the retina and before retina, actually, these are the chambers we talked about, anterior, posterior, and all those things. So read them. What is the content of posterior cavity?
Vitreous humor.
Very good. What is the content of anterior cavity?
Aqueous humor.
Aqueous humor. Very good. Now we come to after that light reflex, we come to the second most important physiological concept is this changing in the shape of lens. What is the purpose of changing shape of lens?
Accommodation.
Accommodation. Very good. Now I told you in my lecture to remember the sequence of event occurring when a person is looking at near object or far object. Okay. I told you very clearly to remember the sequence. So again, because it is very important and because it is confusing to the student, let me repeat. Okay. So whenever a person is looking at far object, okay, distant vision. Whenever a person is looking at a distant vision, the lens you require is thin, isn't it? You require thin lens because the object is far away. You don't need to bend it a lot. Normal bending will cause the light to go on the receptors. Okay. So how lens will become thin? When the ligament become tight. Okay. The ligaments which are there, they have to become tight. They will pull and the lens will become flat or thin. Please remember the word flat or thin. Okay. And how do you pull this ligament? By relaxing muscle, not the contracting muscles. By relaxing muscle. Please remember once again, muscles are relaxed, ligament become tight, and lens become thin. Okay? Okay? This is for
yes.
this is for
Distant.
Distant vision.
Far.
far vision or distance vision. Am I right?
Yes.
Now we go to another scenario. When the muscles contract, ligament becomes relaxed, lens become thick. So we have contract, relaxed, and thick.
Thick.
Okay? Can you remember this?
Yes.
Yes.
Okay. And this is used for
Close. Near.
Near vision.
near vision. Okay? Clear?
Yes.
Close vision or near vision. Please remember this sequence. I cannot stress more. Please remember that. Okay. So what is bending of light called as?
Refraction.
Focal point?
Bending of
Refraction,
light
right?
is called as refraction. Okay. It is bending towards a point. That point is called as fovea. Okay. Or on the retina, where there are maximum receptors. Which are the structures which cause bending? Cornea, lens,
Lens
and humor.
humors.
Maximum refraction occurs at which structure?
Cornea.
Cornea. Okay. Which structure has the ability to change the refractory power?
Lens.
Lens. Okay. So once again, what is bending of light called as? Refraction. Which structure causes refraction in the eye? Cornea, lens, and humor. To which structure this bending helps light to focus on? On the fovea centralis. Okay. And which structure has got maximum refraction ability? Cornea.
Cornea.
Which structure has got ability to change the refractory power?
Lens.
Lens. This is how sequentially you should remember from one slide. Okay. Okay. Now we come to accommodation reflex. It is the reflex which adjusts the refractory power of lens to focus nearby object. Okay. So what is the disorder you know related to this accommodation reflex?
Presbyopia.
What is that?
When age is increased, the accommodation ability is decreased, right?
Very right. So what happens?
You can't see near objects.
They can only see.
So what is the typical case scenario for that patient? What
an
complaint will
old
come with?
man trying to read.
How old he is?
Old, like 60, 70.
70, 60?
No, after 40.
After 40?
Yes.
Okay.
So usually history will have person with age more than 40, 40, Arbain. Okay. More than 40 years. After that, you see all your parents or elder persons you have. Anybody more than 40 years, usually he will need glasses to read. Isn't it? Reading glasses he will require. So this is what it is. Presbyopia. Okay. Are we clear?
Yes.
Remember this picture and you will know the case history very nicely. Okay.
Okay, inshallah.
Okay. So in general, when we are looking at a near object, our eyes not only do accommodation, yani change in the shape of the lens, they will do pupillary constriction and conversion of visual axis. So together all three are called as near response. This is what you should know. Near response yani convergence, pupillary constriction and accommodation. Okay. Here we have clinical conditions related to that. Okay, 3 conditions are there or 3 or 4 conditions. Please remember them. Wherever clinical cases are there, they can always be asked because this is the purpose of our studying physiology to diagnose clinical condition, isn't it? So first condition, myopia, also called as nearsightedness. Yani person can see near things but cannot see far thing. Is everybody clear with the meaning?
Yes.
Yes, sir.
Very good. Second thing which you have to remember, the cause is usually the eye is too long. Too yani more than normal, long. Okay? Or the lens is bending the light too much, too strong lens. So second thing you have to remember here, long eyeball or strong lens. Third thing which you have to remember is the treatment, concave lens. Okay, so that is myopia. 3 things you have to remember about this condition, 3 things about this condition. Hyperopia. Person can see long distant things but cannot see properly the near thing. Why? Because eye is too small or lens is too weak. How it is treated? Convex lens. Okay. So these things will be mentioned in the question in history form. So you have to identify this person is fulfilling these criteria, 2 or 3 criteria, and the person is having hyperopia. Okay. Now very important two condition. What is astigmatism? Somebody, instead of me telling, somebody tell me what is astigmatism?
Uneven curvature of cornea or blurry vision.
Yes.
Yeah.
Yes. So please remember that blurring of vision occurs because of uneven curvature of cornea. You can see in this picture, all the light is not focusing on one point, but it is focusing on three different points. Okay, so this occurs when there is uneven curvature of cornea. Can everybody remember this?
Yes, yes.
Yes.
Astigmatism. Hope it is not a new word to anybody.
Yeah, it's not.
Astigmatism. It is because the surface area of cornea is not
It's
fully
uneven.
curved. There is some uneven angle to it, isn't it? So that is our astigmatism. Then we go to the last one, cataract, which somebody called me that it is
Beda.
Maya Abiyat.
Yes, أبيض.
Maya Abiyat, right?
Yes.
So remember that. Okay. So some anatomy about the retina is there in this slide. You know this anatomy. What is this structure called as?
Retina. Macula.
No, this one.
Macula.
A cap.
This one. You can see my pen marking.
Yeah,
Yes.
yeah, the red one.
Optic disc.
Macula.
Somebody said. Optic disc.
I said cap, but I think the cap was this order.
You said cap. I don't
Yeah,
know what is cap.
No, it was something with capping. I'm not sure.
Oh, you are saying cup. Okay. Glaucoma, it occurs there. Okay, anyway.
Yeah, I'm not sure.
Okay. Okay, anyway, the thing which you have to identify, this is optic disc. There are no receptors here. What is this structure, this black circled structure? Black circle. Inside this, what is there? This is macula.
Okay.
Can you remember macula?
Yes, okay. Macula and optic disc.
Yes,
And
this is
retina.
macula and this is optic. Yellow structure is optic disc. There are no receptors here. This area is macula where there are more receptors than any other part of retina. Okay. In the macula, in the center, there is a point that is called as fovea centralis. So our accommodation, near response, and all the lens and cornea, what they are doing? They are focusing the light on this point. This is the point. This is called as fovea centralis. Okay, please remember that.
Doctor, which one had no receptors?
Optic disc. Why there are no receptor here?
I'm not sure.
Because this is the place which is a bob of the inside the eyeball.
Blind
Anything
spot.
coming inside the eyeball or going out is using this gate. It is only a gate.
Okay. Yes,
Okay.
yes.
Remember that. So you can see arteries and veins coming in or going out of this structure. So it is a gate. So there are no receptors here.
Yeah.
Here, okay.
Very good. Now let's go ahead into the details of the retina. I told you to remember 5 cells in the layers of retina. Can you tell me the names of those 5 cells? Forget about these layers. You know these layers are there. Okay. What are the 5 cells?
Bipolar cells.
Rods and cones.
So we have first receptors. They synapse with bipolar cell.
Bipolar cells.
And bipolar cell synapse with ganglion cell. Okay. If I say the receptor synapse with ganglion cell and then ganglion cell synapse with bipolar cell, am I right or wrong?
Yeah. You're right.
Am I right?
Doctor, can you say it again?
If I say the receptor synapse with ganglion cell and ganglion cell synapse with bipolar cell, am I right or wrong?
Are the optic nerves bipolar?
The question is very simple. Please remember this. In the retina, receptor cells are there. They will synapse with bipolar cell always, and bipolar cell will synapse with ganglion cell always. Okay? we have receptor cell here. They will always send the information to bipolar cell, and bipolar cell will send the information to ganglion cell, and the axon of ganglion cell will go to the brain. Are we clear?
Yes, okay.
All of you, are we clear?
Yes, doctor.
Please remember the sequence. Receptor cells, rod or cone, will synapse with B, bipolar cell. R will synapse with B, bipolar cell. Bipolar cell will synapse with ganglion cell. Okay? And axon of ganglion cell make optic nerve, which will go to optic pathway and brain. Simple?
Yeah.
Yes.
Okay. In between receptor cell and bipolar cell, we have horizontal cell in between them, just to increase or decrease their function. Similarly, amacrine cells are between bipolar cell and ganglion cell.
Ganglion.
Okay?
Yes.
This is just a simplified version. Actually, both these cells are everywhere. Okay? Just to make things simple, I have said like this. Okay. But please remember the sequence of these three cells. Okay.
Yes, okay.
Okay. Now you know the receptors are having these two structures. One is the protein part and the other one is vitamin A derivative. The only sentence which is very, very important, which you need to remember is, where is that sentence? Here. Okay. The only light dependent step in the entire process is conversion of 11-cis retinal to all trans retinal. So whenever light comes to the receptor, the only change which occurs in the receptor is the vitamin A 11-cis form converts to all trans form. Easy?
Yes, easy.
Rest, forget. This is the only thing you have to remember. Okay?
Okay.
Sorry. Okay. Of the rods and cones, there are differences. You please remember the important 4 or 5 I have told you. Let me ask you in short one question. Of the rods and cone, which is more sensitive to light? Answer?
Rods.
Yes. What is the answer?
Rods is more sensitive.
Therefore, it can see
Yeah.
during night.
Day. Yeah.
Isn't it? When there is less
night.
light. Okay. Very perfect. Okay. Rods are sensitive to light. So small amount of light also they are able to detect. Therefore, they are good for night vision. Please remember the other differences also. Please remember this sentence. This is I have already repeated. Okay.
So, doctor, rods for night vision and cones for day vision.
Oh, yes, very right. And cones have another function also. Can somebody tell me?
Low sensitivity.
No, another function is related to color. You are right. It is low sensitive, but extra function cones do is they detect
light color.
They
colors.
detect color.
Yeah.
Rods do not detect color. Okay.
Okay.
Remember that. Okay. Okay. So now we have come to the anatomical part. The pathway is shown here. Can you tell me the branches? Again, it is anatomy. So let's leave that. Here is the lesion, clinical scenario here. What will happen when there is damage to optic nerve of one eye?
Unilateral blindness.
Very good. Please remember the question words I am using in the question, and please remember the answer also. What will happen when there is damage to optic chiasma?
Bilateral.
Bitemporal.
Bitemporal.
Bitemporal, I mean.
Yes, as I said, Remember the word in the question, remember the word in the answer. So, optic chiasma by temporal hemianopia. What will be the lesion finding when there is damage to optic tract? Complete damage to optic tract.
Homonymous hemianopia.
Homonymous hemianopia.
Very good. What will be the problem when there is damage to optic radiation?
Homonymous hemianopia with macular sparing, yeah.
Good. Now you got the terminologies clear. We have optic nerve,
Yes.
optic chiasma, optic tract, and optic radiation. Okay? And you know the answer which are mentioned here. Very good.
Okay.
In the thalamus, there are two types of pathway. Please remember them. This is one of the very unique thing. Okay? So the magnocellular pathway is important. Magnocellular yani large cell. Important to detect movement, depth, and flicker. The parvocellular or small cell pathway is for details of vision, color, texture, shape, shape, and other details. Okay. How many different types of cones are there?
3.
Three kinds. Because cones detect color, we have different cones for each primary color, red, green, and blue.
Mm.
So that is all for this lecture. Any question?
Thank you so much, doctor.
You.
We have the last two left, right?
Yes, hearing is the last one now because the rest we have covered already.
Ah, yes. Okay.
19, 20, 20 and 21 we have already covered as today's lecture. So
And
there is nothing.
SDL we should study alone, right?
Yes.
Okay.
Are you able to see the PowerPoint now?
Yes, we can see.
Yes. Okay. So regarding this lecture number 18 and 19, it was for hearing. We talked about the stimuli, that is sound. Regarding this particular stimuli, sound energy, please remember the importance of the property of this sound. What are the physical properties of the sound? Quickly answer me.
Frequency, amplitude, and direction.
Yes. Yes. So mostly frequency and amplitude are the two important properties of the sound, and we use it for identifying some information. What is the importance of amplitude?
Was it for the tone or
Wrong.
pitch?
Pitch.
Wrong. Wrong.
For the loudness.
Loudness. Right.
I confused between them.
So that is the reason we are revising things again and again. Simple things are there, but we get confused, isn't
Yeah.
it?
Yeah.
Amplitude is the height of wave. Amplitude, okay? So it is the largeness or smallness of wave. So that will talk about loudness of sound. Okay?
Frequency
brain
is for
understand?
the tone?
Frequency is for the tone and pitch.
Exactly.
Yeah, okay.
Okay? Frequency of the sound waves will tell us about the sharpness, tone, or pitch of the sound. Amplitude will tell us about the
The
loudness of the sound.
Loudness.
Please be very clear. This was our first important point in this lecture. Second is the frequency we can detect is between 20 Hz to 20,000 Hz. Yes, 20 to 20,000 Hz. Now, this is where it is given loudness, amplitude, pitch and tone, frequency. Good. Now we come to the ear itself, and the anatomy was explained to you. Here in anatomy, we don't go into a lot of details. Simply, you need to know the function. So, what is the function of external ear?
Collect the sound.
Collecting
Direct the
the
sound towards
The tympanic membrane.
tympanic membrane. Second is localization. These are the two functions. Middle ear, what is the function? Transferring sound from tympanic membrane to inner ear. Second function is impedance matching. Third function is attenuation.
Okay.
Clear?
Yes.
Very good. So these are the three functions we have to remember. You should know what is impedance matching. It is the overcoming the resistance of sound to the sound wave. Okay. Okay. Attenuation, you know, it is a protective reflex. Now we go to the anatomy of the inner ear. I described you the whole tube and their partition. In this thing, the most important thing is the middle cavity, which is called as scala media. Okay. Second thing which you'll remember is the floor of scala media. It is made by basilar membrane. This is important because we have organ of Corti in the middle cavity, scala media. So organ of Corti is a very important structure because it consists of receptors for hearing. What are receptors for hearing called as? Answer.
I don't remember.
Hair cell.
Oh, herself.
Okay.
What?
Yeah.
What is the Arabic word for hair?
Shar.
Shad.
Char.
Yes.
Right?
Yes.
Yeah.
Okay. So that is a hair cell. Okay. So that is the answer. Hair cell are the receptors. Okay. Second thing you have to remember about is the hair cell are in two groups, inner hair cell and outer hair cell. Please remember their function. I don't know where here it is given. Okay. Hair cell, inner hair cell. Please remember, inner hair cell convert the sound energy, mechanical movement into action potential, auditory transduction. Okay. What is the function of outer hair cell? They simply change the sensitivity of inner hair cell. Are we clear till this point?
Yes.
Very good. Now let us go ahead. Okay. What is the function of inner ear?
Sensory transduction.
So it has got receptors which will convert sound energy into action potential. Second function is identifying the frequency by using place principle. What is place principle?
To detect sound frequencies.
Yes, the mechanism of place
There were
principle is
fibers.
The position.
in the fibers in the basilar membrane. So the basal fibers in the base area, they will tell us about high frequency. Fibers in the apex area of the cochlea, basilar fiber,
Low frequency.
they will tell us about the low frequency. So this is how, based on the place on the basilar membrane where vibration is occurring best, our brain is able to identify the frequency. Okay, that is place principle. Then we have auditory pathway. If somebody understand it, teach me. Okay.
Okay.
Now we come to the last part here, second last part of the physiology, that is localization of the sound. How we identify the direction of the sound. Which two words you will remember?
Relative intensity and timing.
Intensity and timing.
Exactly. So we identify the direction of the sound, or we identify the localization of the sound by relative intensity and relative timing. Okay. Please remember these two words. Okay. Tell me what is conduction deafness and what is sensory neural deafness.
The conduction deafness, external ear and middle ear.
Any problem or obstruction.
Yeah.
Okay, how do you get a white slide?
You can add a white slide. Okay.
Yes. Very good. So we have, how many ear are there?
3 parts.
3 parts are there. One is called as?
External ear.
External, middle, and internal.
Very good. So we have 3 parts to the ear: external, middle, and internal ear, isn't it?
Yes.
If there is damage to this part, what type of deafness will be there?
The
Conduction.
obstruction, the
Conduction.
first type.
Deafness.
conduction.
If there is damage to this part of the ear, which
Neural.
type of deafness will be there?
Sensory neuron.
Neural. Sensory neural.
Sensory neuron. If there is damage to this part of the ear, which type of deafness will be there?
Conduction.
Conduction.
Conduction deafness. If there is damage to this part of the ear, which type of deafness will be there?
Conduction.
Conduction.
Okay. Now, if I give you a 1-page long history, will you be able to identify which part of the ear is damaged? I'll give you clear-cut clues.
Yes. Yes.
Then will you be able to identify which type of deafness is there?
Yes.
Yes.
Sure.
Okay. Okay.
Yes, you will
Now
say
I can
external.
ask you. Sorry?
You will say external or middle or internal, right? Inner, I mean.
Yes, I will give you the location, or I will give you the deafness and I'll ask you the location, or I'll give you location and I'll ask you the deafness, isn't it? One of the
Yes.
two.
Okay.
Simple?
Yes.
Yes.
I will give you clues as to where damage has occurred and I'll ask you the type of deafness. Okay?
Okay, yes.
The person may have. Or I'll tell you the person is having this deafness with these things. Then I'll ask you whether the damage is here or here or here. Sufficient clue will be there to tell you where there is there. Okay?
Okay.
You should be able to identify. Okay?
Yes, okay.
So let me give, do you want a practice question here?
Yes, no
No,
problem.
it's fine. It's clear.
If you want, yes, doctor, no problem.
It's up to you. Yeah.
Okay. Okay, let's practice here. Okay. A person was brought by the son. A father was brought, 60-year-old father was brought to the hospital saying that he is not able to hear properly. Okay. So the doctor examined the ear and everything, and he did the audiogram test also. Okay. So the audiogram test proved that the person is having sensory neural deafness. On examination of the ear, there was no problem in the external auditory meatus and no problem in the middle ear. So what is the site of the
Inner.
inner ear?
Inner.
Because he is having sensory neural deafness and the other two are
Yes.
normal, isn't it?
Yes.
Another patient was brought. His audiogram was done and it showed conductive deafness. On examination, there was no problem in the external auditory meatus. What is the most probable
Middle.
site of lesion?
Middle.
Middle ear.
Middle, sure?
Yes.
Yeah, you said external was fine, and you said it was conduction, so it's
Very good. You have used both the information to identify the site of lesion. This is what you have to do. Okay? If
Yeah.
you are not able to do, don't come cry. Are you clear?
Yes, thank you,
Yes.
doctor.
Very good. So we have finished this discussion. What is presbycusis?
Partial hearing loss.
Hearing loss due to
Old age.
old age.
Degeneration.
Just like presbyopia.
Yeah.
Okay. So similar to that, this is old age.
Old age.
Hearing loss due to old age. It is not 100%, it is always partial. That is all you should know. So this is all about the hearing lecture. The remaining are smell and taste. We have already covered. So any question?
Yes. No, thank you, doctor. Everything is clear.
Thank you very much.
Thank you very
And
much.
thank you
best
doctor.
of
for
luck
your
for the
time.
exam. No issues at all. Thank you very much and best luck.
Thank you.
Inshallah, easy exam.
It is always easy. Physiology is always easy.
Thank you, doctor.
Sure. Okay. Bye.
Bye. Have a nice day.